Hi, my name's Jim White, and I'm a professor at the University of Rochester Medical Center in Rochester, New York. I'm the founding director of our Pulmonary Hypertension Association accredited comprehensive care center. And today, as part of the Simply Speaking PAH series, I'm going to talk about the history of accreditation, what it means to be an expert center, and what it means to be part of the clinical investigator community. I hope you enjoy today's relaxed format program. When people ask me, why is it important that there be a center of excellence or an expert center or accreditation? What's the history of any of this? I talk about how the early days of pulmonary hypertension were strictly centers of excellence. Half a dozen places in the United States were using intravenous Flolan in 1996 when it was approved. And for the following 15 years, there was a progressively more Wild West with providers saying they knew what to do with pulmonary hypertension patients. And yet, what that meant at each institution was very different. And especially in some smaller private practices, advertising to patients that they were an expert became a real problem as drug choices became more variable and as people recognize just how sick these patients can be. In fact, the mortality in pulmonary arterial hypertension group 1 for a functional class 3 or functional class 4 patient can be as high as 50% at 5 years. And though those numbers are improving, they only improve when a real expert is involved. What are the essential components of an expert center? So, for example, at the University of Rochester, I'm the founding director of our comprehensive care center, and I'm trained as a pulmonary physician. And although I joke about being an underpaid right heart failure cardiologist, the truth is that I'm not a board-certified cardiologist. I am not, for example, trained to do coronary angiography or percutaneous coronary interventions. And although I can and in the past have done my own right heart catheterizations, I would be limited in terms of left heart catheterizations. And so each comprehensive care center needs access to the things that the program director doesn't provide. Who are the multidisciplinary members that should be part of an expert care team? In terms of who ought to be a part of a comprehensive care center, certainly the full-time provider and the full-time program coordinator, yes, but also a collection of people around them. And so most of the time that is two physician specialists who are dedicated to pulmonary hypertension. Perhaps in an optimal world, that would be a pulmonary physician and a cardiologist sharing the responsibilities, so that both sets of expertises are brought to bear for the optimal care of patients. In some cases, that's two cardiologists, and at the University of Rochester, it's two pulmonary physicians. But here at the U of R, I have a wonderful collaboration with the director of our cardiac catheterization lab. And in fact, we are actively participating in procedurally oriented research studies like the ARIA device, like the Artisan study. We are actively participating in device-oriented trials that Fred Ling is the sub-investigator who does that invasive cardiology studies. Similarly, I suspect at places where a cardiologist leads, they have the input of pulmonary physicians to understand how ILD and COPD are influencing the patient in front of them, and to get good expertise about the interpretation of a VQ scan or a CT scan, so that the best knowledge in pulmonary medicine and the best knowledge in cardiology and invasive cardiology is brought to bear in the care of each patient. Social workers, incredibly important in advancing our care and increasing our equity and justice in the delivery of healthcare, especially to patient populations that have been discriminated against and underserved. And so the social workers familiar with how to provide outreach, how to knit together the social structure supports to bring the best care to patients who are often fragile, often needing our social service net programs, Social Security, disability, Medicare, Medicaid, and struggling with food insecurity and housing insecurity. And so we need social workers as part of that team. We need pharmacists as part of that team to look for complex drug-drug interactions, especially for our immunosuppressed patients. We certainly need respiratory therapist who delivers competent studies, and we need nurses who can help us with the demands of parenteral therapies. In some places, we're going to want ECMO support, although there are comprehensive care centers that don't have ECMO support, and it is certainly not an established part of the care hypertension patients outside the transplant center. And then, of course, that initial nucleus is surrounded by a much larger nucleus, and especially, again, at a transplant center. And not all comprehensive care centers are transplant centers, but we're definitely going to want, in that outer circle, we're going to want people who are top-notch cardiac anesthesiologists. We're certainly going to want palliative care physicians to help with those discussions, although certainly I would like to think of myself as being very competent in palliation and in goals of care discussion. For places that are taking care of a large portal pulmonary hypertension population, you want your colleague support from hepatology. We certainly need well-educated ICU physicians when our patients are the sickest of the sick. What are the two types of centers, and what are the accreditation criteria? So in 2010, the Pulmonary Hypertension Association, a collective of patients and caregivers and expert providers, decided to embark on a process to create accreditation. And that accreditation process resulted in the establishment of two different kinds of treatment programs that could be accredited. The first is the Comprehensive Care Center. And the Comprehensive Care Center is the pinnacle of accreditation. These places are established leaders in clinical care and in contributing to the research that helps to improve care. And the regional clinical programs are the programs that support and are aligned with centers of comprehensive care, but are closer to the patients. So, for example, one can think about it as a hub and spoke program, where the hub might be in New York City and regional clinical programs might be 90 minutes, 2 hours closer to home for patients who live outside New York City. And it really is intended as a hub and spoke program. That is to say, patients might have an initial evaluation, an echocardiogram, pulmonary function testing, right heart catheterization at a regional clinical program with a solidly trained physician and a collection of providers around that person. But when parenteral drugs are necessary, when hospitalization for a patient deep in heart failure is necessary, they have an alignment, a relationship with a center of comprehensive care so that that patient can get everything that they need, including the opportunity to participate in research. And it really, this hub and spoke model is supposed to be the final destination, if you will, for the PHA vision of having comprehensive care centers and regional clinical programs surrounding them, so that all patients have access to real clinical excellence for this rare, often rapidly progressive, and unfortunately often fatal disease. I'm showing now the map, which shows that there's, somewheres in the neighborhood of 50 or 60 accredited adult centers of comprehensive care, and a growing number of regional clinical programs, hopefully aligned closer to patients in the communities that aren't served by a center of comprehensive care. In terms of what it takes to become a comprehensive care center and the differences between regional clinical programs, well, of course, we're going to expect the program directors for both of those to be experienced physicians, board certified in either cardiology, pulmonary disease, and regularly completing and contributing to continuing medical education. Obviously, we want these people to be members of the the Pulmonary Hypertension Association as providers or researchers, the Clinicians and Researchers Network, and we certainly want them to be employed as providers by the institution that's being accredited, and especially to have a dedicated time for pulmonary hypertension. There's an important difference. We only expect the regional clinical programs director to be 25% dedicated as a full-time equivalent, whereas we expect the comprehensive care center's program director to be a full-time equivalent or two part-time equivalents. We expect both programs to have access to respiratory therapy trained or registered nurse trained or advanced practice nurse, physician assistant trained, somebody in with a significant licensed healthcare role to be the program coordinator. And we expect these people to have a sensible amount of proficiency relative to the regional clinical program versus the comprehensive care center. Finally, in terms of the difference between the regional clinical program and the comprehensive care center, there are expectations about parenteral prostanoids for a comprehensive care center. There's expectation about patient volumes at a comprehensive care center, and there's expectations about the contribution to education and research at a comprehensive care center that are more significant than the regional program, as you'd expect. So we talked about research as being a key differentiator between the comprehensive care center and the regional clinical program. And that's not, again, it's not supposed to be a penalty, but rather an invitation. The point is that for a disease like pulmonary arterial hypertension in group 1 or group 3 or group 4, the rare nature of this disease means that it's actually hard to do the clinical research that advances the care of patients. And one of the things that the Pulmonary Hypertension Association sought to do in establishing the comprehensive care center was to create a standard that said the pinnacle of clinical care in this disease has to include research. So who is part of that research, and what does it mean to achieve the research accreditation for the comprehensive care center? Well, it means that before you're accredited, you have to have been a participant in 3 separate IRB-approved PH clinical trials. Those could be ones that you initiated or ones that were initiated outside your institution. You have to have dedicated research staff, because if your institution isn't helping to pay for dedicated research staff, there is no research program. And all of us who do it know that. You need access to an investigational drug service, because not everything comes in a pill, and you need to have injectables as part of your research service, and that means having an IDS. Your institution has to have some sort of relationship with an IRB, either a central IRB or its own IRB. And you have to have been involved in at least one publication that reports the findings. And again, whether that's a publication that you drove on your own or a publication that you made such a significant contribution to a multi-center project that you're included as an author, either is fine. And now we're trying to use the Pulmonary Hypertension Association's registry, the FAR, to reach even further, to enroll patients at the time that they establish with a comprehensive care center or a regional clinical program, and to follow them over time to establish a contemporary registry of patients, not all of whom are newly diagnosed, but many of whom are newly diagnosed, and all of whom are newly followed at a CCC or an RCP, to see how the adherence to standards of care results in outcomes. I think that covers the comprehensive care center and regional clinical program pretty well. I want to encourage everybody to think about this as an invitation to excellence. That's certainly how the scientific leadership committee thought about the introduction of regional clinical programs and comprehensive care center, an invitation to be the best, an invitation to provide the best care, an invitation to achieve standards that would benefit the patients that you care for. And so that's how we thought about the comprehensive care center when it was initially developed. That's how we thought about regional clinical programs when they were invited to be this hub and spoke model. And we hope, of course, to show that these types of invitations to excellence result in better patient care for the entire community. Having established that research is an important part of the invitation to excellence that Comprehensive Care Center is, then who can become a clinical trial investigator? And I would say the answer is maybe you. So to really highlight research versus clinical care, in clinical care, you are applying the medical knowledge that's out there, the medical knowledge that's in up to date or in the New England Journal of Medicine, the medical knowledge that was passed on to you in residency and fellowship, the medical knowledge that you've accumulated in day-to-day care of patients. You are trying to take care of the patient in front of you using that collective knowledge to the very best of your ability. Clinical trials mean that there is an approved protocol that a human subjects institutional review committee has sat down and said this protocol is acceptable in terms of its risk and benefit analysis. And the scientific community has usually said this addresses a question that is of importance. And whether that question is about the application of a new technology, like a way to image the right ventricle, or a new blood biomarker that is being tested for its diagnostic or therapeutic acumen in the care of patient, or a new molecular entity, or a new combination of drug therapies, or a new strategy, some sort of research question is being addressed. And the protocol that's approved addresses that question in a way that will be rigorous and meaningful at the end. In terms of who is a clinical trial investigator, I think in pulmonary arterial hypertension, the majority of clinical investigators are full-time employees of academic healthcare institutions, private or public. There are very competent pulmonary and cardiology physicians in large private practice settings who've made excellent contributions to clinical trial investigations over the years. And so you don't have to be at a university, but at least in pulmonary arterial hypertension, most are. And everybody, including me, was new at one point, right? So the first time that I was participating as a clinical trial investigator was the ARES study to approve ambrisentan. As it turns out, we didn't enroll anybody. We screened some people. My second clinical trial was tadalafil, and in fact, we were lead enroller, and I'm an author on that study. So everybody has to be new sometime. You don't have to have done it to do it for your first time. In terms of what you do as a clinical trial investigator, the first thing that you have to do is you have to figure out who the teammates are going to be. That is by far number one. You have to figure out who those two teammates are going to be, and then collectively you have to educate yourselves in the ethics of human subjects research and in good clinical practice. GCP accreditation for yourself and for your teammates is going to be the stamp of approval that's required by almost every drug sponsor, and certainly ought to be the mark of approval that you seek when doing your own investigator initiated trials. And then that will all lead to everything else, right? You will get to assess medications, get to assess procedures, get to assess imaging techniques, get to assess diagnostic tools or strategies. And as you start to understand more about protocols, you will educate patients so that you can recruit them to participate in research and do so in a way that's contemporary with good clinical practice and a way that's ethical. So you've assembled your team and you've gone through the initial training steps and you want to break in. How do you become a clinical investigator in pulmonary arterial hypertension? And I would just encourage you, the first thing is you're going to try to network at meetings, right? You're going to find out who the sponsors of trials are and go to posters and talk to people at CHEST, at ATS, at AHA, and start introducing yourself as somebody who's done their training and formed their team and really kind of wants to put a flag in the ground and make a contribution. And so I would encourage you to seek out the sponsors and make yourself available. And once they come and start checking you out for a site qualification visit, then you get as prepared as you can. Make sure that you know the protocol, you've read everything in advance, your team looks prepared, and everybody's got on their Sunday best, if you will, when the site qualification visit happens. And make it clear that you personally have invested in learning the protocol, in looking at the inclusion and exclusion criteria. You form your team and you start with the training, GCP and human subjects investigation. And then there are further accreditations that you could seek, including becoming a member of the Academy of Physicians in Clinical Research. And there's a website that's a part of the slide deck that I would encourage you to look into. And hopefully you will have the privilege of getting to record your findings in presentations at meetings and in publications and journals. They're going to ask you, how do you assess patients for eligibility? And your team needs to be a part of that, because that's how it's actually going to happen. If it's going to be successful, you're not going to look at each individual patient. Your team is going to have to help you do that. And then the next step is the hard one. If they say, yes, we want you, then your job is going to be to make sure that your institution gets the contract and budgeting right. And this is no small task, my friends. Making sure that the budget is going to meet your needs, so that the team members that need to be a part of this can be paid, that the institutional requirements are met, so that if it costs this to do this at your institution, the budget says that, and it's business, right? And then once the contract's signed, the day of site initiation comes, and then, at least here in Rochester, my team knows that I expect that after site initiation, we're going to be prepared to enroll our first participant in the next 2 weeks. And that's because it's fresh in everybody's mind, right? Site initiation, you went over the protocol, you went over the eligibility requirements, you choose that first person, you make sure that the person meets the eligibility requirement, and you do that yourself as part of your further training for the team member. And when that person signs consent, you make sure that the team gets a big bottle of champagne that day for having facilitated that first step of success. And then you want to continue enrolling. And at least here in Rochester, our strategy, as we were small, was to pick one study and really do well with that one study. And then we grew into other studies as we grew as a team. So we've talked about how you go and start your journey in clinical investigation. Now, what are the general responsibilities of being a clinical trial investigator? In terms of your responsibilities, your responsibilities are tremendous. So that the investigator is responsible soup to nuts. So from the site qualification visit, where you worked on the protocol and made sure your team knew the protocol so that you could talk intelligently and convincingly to the sponsor about how you would conduct the study, to making sure that you understand the safety problems with the drug as the trial progresses, that you are making sure that each of your teammates is adhering to the conduct of the protocol, that each study visit is being conducted appropriately, that you welcome the monitors to do the monitoring visits, and that you're available yourself for those monitoring visits, that you make sure that the patients understand what their responsibilities are, and that they're being adherent to the protocol, and that they feel valued. Your main responsibility is to ethically recruit patients and to ethically shepherd those participants through the protocol in an adherent way. And there are many ways that, for example, a clinical trial sponsor of a medication or a device will help you to achieve that goal, including making sure that you have read the investigator's brochure and the protocol. They'll gone over the key information with you at a site investigator's visit, and then ask you to sign the investigator statement and the training log. Why should you become an investigator? Why? Why should I do all this? This sounds like a lot of work. Well, the answer is because it's the greatest satisfaction that I've had in taking care of patients, to participate with them in shepherding new drugs. When I started out doing this, the parenteral treprostinil was a core part of the therapy. Still is, of course, but in those days when you were on a single oral drug like Bosentan or sildenafil and you were failing, we always reached for parenteral treprostinil because that was what worked. And so participating in the AMBITION study and establishing that initial combination therapy was a revolution, really a revolution in the care of these patients. That was so exciting. We enrolled, 15 people in AMBITION. And every time I saw one of them, I said, you are helping to change the face of pulmonary hypertension. You are helping to change outcomes in this disease. In the future, people will have easier access to insurance approvals because we'll have better labels and better indications for the disease. So we are helping to deliver life-changing, life-saving therapies that are easier for patients to use, therapies that improve outcomes, therapies that might actually extend life. One of the things we've done well in Rochester is make sure that the patients understand that they are the key to research, not our team, that their participation is the key to research. And as a part of doing all of this, you get the tremendous satisfaction of knowing that you're helping to change lives, and also you'll enjoy a greater leadership role as I have over time, and getting to help shape people's decisions about which drugs get selected, about how the protocols get conducted, about what it means to assess risk and to find new ways to assess risk. And, that's a fun career. It has been a very fun career. How do I incorporate clinical trial investigation into my practice? The answer is you need to be really excellent in clinical care before you can start thinking about who's right for research and incorporating research. And where we think about this is when, for example, we have a patient who's doing pretty well on initial combination therapy, and we're looking at using prostacyclin class therapies, which are approved, or looking at research, which is not approved. And how I think about that is, well, there's burden associated with these therapies that are approved. There's the unknown in thinking about a placebo-controlled trial for an investigational therapy. And the sweet spot, in my opinion, is the patient who is doing okay and is not at high risk for deterioration, but could be better. And that's the patient where I think you really incorporate research into your daily clinical practice, and you offer that person the opportunity to be in a clinical trial to develop something new and exciting that might be easier to take, that might be less burdensome in terms of side effects. And that person then is a great person to contribute to clinical trial research. Obviously, a trial like the Zenith study of sotatercept is a trial for the worst of the worst, right? The patients who have no alternatives. And that's a different kind of clinical trial. But usually I think about clinical investigation as the intermediate risk patient who could use to be better, who has some symptoms, who would like to be better, but who's not really on the edge, who doesn't definitely need something more and something quickly. What is an IRB, and how does an investigator work with the IRB? The Institutional Review Board, or at the University of Rochester, the Research Subjects Review Board, that is the group of people, usually a physician, usually a person from the lay community, perhaps a pastor, often an ethicist, usually somebody from the allied health community, a nurse, oftentimes a group of people from the institution who sort of represent the institution as faculty members or staff members. The Institutional Review Board is a group of people who are committed to promoting safety and ethical behavior. And the Institutional Review Board looks at the protocol, assesses the risks that are enumerated, assesses the potential benefit, and makes sure that, for example, the protocol appears to balance risks and benefits, and that the consent form accurately describes those risks and benefits. It's your responsibility in interacting with the IRB to make sure that you follow the protocol, of course, but also that you report deviations from that protocol. We're humans, we make mistakes. It's really important that we be upfront about that with the IRB so that the IRB can supervise us in assessing the impact of our mistake and assessing any sort of rehabilitation that needs to be done as an investigative team. And I've been audited by the FDA. I've been audited by sponsors. We've submitted to our own RSRB audits here at the institution. It's an important process of quality improvement to submit to those audits and to respond to those findings, to admit one's own mistakes and to figure out how to be better. So today, I hope that this relaxed fireside conversation has been helpful in understanding the importance of an expert center and the Pulmonary Hypertension Association's response to that with the establishment of comprehensive care center and regional clinical programs and the exciting FAR registry that emerges as a root of our labors in forming expert centers, and then to emphasize how clinical trial investigation has become a cornerstone of care in pulmonary arterial hypertension, and how clinical trial investigation has changed the face of this disease for so many patients and will continue to change it in the future. I hope you've enjoyed our chat/program, and I'd encourage you to go to the Practice Point website where you can evaluate whether you thought this was any good or not, and also collect your credit. Make it a great day.